being the SPHIS 2016 Alumni Fellow, and also thanking him for his willingness to come and present today and describe one of his more recent investigations.
Thank you. Yeah, well, good afternoon, everybody. As Dr. Baumgartner mentioned, I am currently assigned to the National Institutes for Occupational Safety and Health. The outbreak investigation that I'm going to be talking about this afternoon is actually something that I was involved in when I was a career epidemiology field officer assigned here in Kentucky, in Frankfort, to the Kentucky Department for Public Health. And I'll also point out that it was at this period of time that your classmate Stacy Conkle was also working at the Kentucky Department for Public Health, and she actually had a big hand in this investigation. So if you're skeptical about anything that I tell you here, you can confirm with Stacy. I think we've got an hour, and this presentation may take 25-ish minutes, maybe half an hour. I want to leave plenty of time for informal discussion. So maybe somewhat paradoxically, I'm going to give this presentation as I gave it to the CSTE conference back in 2014, sort of CDC or EIS style, which is a little bit dry and scripted, but it will keep me on track and allow me to finish the presentation in time for us to have a more free-ranging and informal discussion about the topics that are covered here. I did modify this presentation just a little bit. I added a couple slides because many, if not most of you are students. I thought it might be apropos to sort of pick out a couple of teaching points that seem to relate to the investigation, and I'll hit on those as I get to them. Whoops. In the first case, the first modification I made is this. So this outbreak investigation is an example of field epidemiology, and obviously of an outbreak investigation. And as I talk about the investigation, what I'd invite you to do is consider these sort of standardly recommended steps in conducting an outbreak investigation, and just sort of ask yourself, or I'd invite you to see to what extent the investigation that I describe here either follows or doesn't follow these steps, keeping in mind, obviously, that every investigation is unique. Not every investigation is going to fit neatly into this, and obviously not all steps are going to be followed, and they don't necessarily occur in this order. So these are 13 steps. This comes from the third edition of CDC's Principles of Epidemiology and Public Health Practice. A lot of times this will be condensed into 10 steps, which is maybe a nice, more round number, but basically it's the same thing. So these are the typical steps involved in an outbreak investigation, and so from a field epi perspective, I invite you to sort of keep this in mind as I describe the investigation. There we go. Well, oh. All right. So, rapidly growing mycobacteria, or RGM, so called because they grow within 7 days of subculture to solid media, comprise a subset of the non-tuberculosis mycobacteria. They're ubiquitous in the environment and can be found in soil and water. Some of the most common clinically important species of RGM include members of the M. fortuitum group and the M. abscessus group, including M. chelotum. As pathogens, these organisms are usually associated either with lung or skin and soft tissue infections. They're also infrequent but increasingly recognized causes of post-traumatic and post-surgical wound infections, and have been associated with surgical implantation of devices, including joint replacement. At least one outbreak of post-surgical RGM infections associated with a colonized healthcare worker has been reported. Infections caused by members of the M. smegmatis group, which includes M. smegmatis itself, and two additional species first described in 1999, M. walenskyii and M. goodii, are much rarer. As recently as 3 years ago, and I'll point out that was 3 years ago in 2014, so I'll say as recently as 2011, only 12 cases of human infection with M. walenskyii had ever been identified. M. walenskyii has primarily been associated with post-traumatic and post-surgical wound infections. On August 13, 2013, the Kentucky Department for Public Health was notified by a local health department of 4 cases of M. walenskyii infection at Hospital A. M. walenskyii had never before been isolated from a patient at Hospital A, and the large national reference lab used by the hospital had only seen 3 other cases in the previous 2 years. All of the case patients had undergone joint replacement surgery at Hospital A 3 to 8 months prior to isolation of M. walenskyii, during October to December of 2012, and all were patients of the same large orthopedic physician's practice. The Department for Public Health initiated an investigation into the outbreak in conjunction with the local health department and the infection control department of Hospital A. The objectives of the investigation were to determine the extent of the outbreak, identify the source of the infections and the mode of transmission, and to implement effective control measures. I'll now briefly describe the methods we employed for this investigation, which had epidemiologic, infection control, environmental, and laboratory components. For this investigation, a case was defined as a surgical site infection or other infection involving skin, soft tissue, bone, or a joint occurring on or after October 1st, 2012 in a patient who had joint replacement surgery at Hospital A within 1 year prior to the infection and which was culture positive for RGM. Case identification efforts included a retrospective review of microbiology lab records, as well as prospective surveillance for new infections. Case patients' inpatient and outpatient orthopedic clinical medical records were reviewed to identify any common exposures such as clinical locations, visit dates, or procedures. The infection control staff of Hospital A observed multiple joint replacement surgeries to identify possible sources of exposure to potentially contaminated water or fluids in the operating room, as well as to assess compliance with hospital infection control policies and adherence to proper aseptic surgical technique by OR personnel. A case control study was also conducted to identify risk factors associated with case status. 5 cases, all of the case patients identified at the time the study was conducted, and 20 controls were included in the study. The controls were randomly selected from among all patients who underwent joint replacement surgery at Hospital A between October 2012 and March of 2013. Data for the study were abstracted from subjects' electronic medical records by Hospital A infection control staff. Odds ratios were calculated for sex, operating room used, day of surgery, time of surgery, that is AM or PM, and for each person present in the operating room during any case-patient surgery. Statistical significance was determined using exact methods. Cases and controls' mean ages were compared using students' t-tests. Environmental samples were collected from surfaces using swabs, and bulk samples were collected from water sources, including from ice machines. Healthcare worker colonization status was assessed using samples collected from hands with hand wipes, hair follicles from the eyebrows and scalp, and swabs of the nares, pinna, and scalp. Any acid-fast bacilli found in environmental samples were presumptively identified using PCR restriction fragment length polymorphism analysis of the heat shock protein 65 gene and confirmed by 16S RNA and RPOB gene sequencing. Clinical and environmental isolates were compared using molecular typing by pulse field gel electrophoresis and by whole genome sequencing. I'll now turn to the results of our investigation. 8 cases were ultimately identified in the course of this investigation. 5 of the 8 case patients were female, and ages ranged from 36 to 71 years with a median of 65 years. 7 of the case patients had undergone total knee replacement. The 8th had a hip replacement. The incubation period, defined for our purposes as the time from the date of the initial joint replacement surgery to the date that the first RGM-positive specimen was collected, ranged from 79 to 288 days with a median of 173 days. 7 of the cases were infections of the surgical site, while 1 was an infection of a remote site, a lumbar discitis. 5 of the cases were infections caused by M. Walenskyii, 3 were caused by M. goodii. 5 of the case patients required surgical revision of their joints. This figure shows the epidemic curve for the outbreak with the date of diagnosis on the x-axis and the number of cases on the y. Due to the small number of cases, it's excuse me, it's difficult to draw any conclusions from this epicurve. This figure shows the I apologize for my voice. I'm getting over a little bit of a cold. So this figure shows the dates of cases diagnosis in relation to their surgery dates. And again, small numbers make the graph difficult to interpret, but it does indicate a potential seasonal pattern of occurrence. The surgeries in which the case patients were presumably exposed occurred predominantly during spring and fall months. Okay, after the initial notification of the outbreak, the Department for Public Health and local health department investigators reviewed case patients' inpatient and outpatient medical records. No common outpatient clinic locations, appointment dates, procedures, or other risk factors could be identified from case patients' outpatient medical records. What the cases did have in common, in addition to the orthopedic practice, was joint replacement surgery at Hospital A. This led the investigation to focus on the hospital's orthopedic surgery suite and post-anesthesia care unit. Surgery observations were made and environmental samples were collected from the OR and PACU. Observation of several joint replacement surgeries by Hospital A's infection control team failed to identify any sources of exposure to non-sterile water or fluid medical products, and no lapses in hospital infection control policies or of surgical asepsis, and no improper surgical techniques were observed. Rapidly growing mycobacteria were cultured from water samples collected from operating room scrub sinks, recovery ward ice machines, and a portable cold therapy unit reservoir, but none were M. Walenskyii or M. goodii. Species recovered included M. sphagnii, M. mucogenicum, and M. abscessus. After the identification of the 5th case, the first of the goodii cases, in September of 2013, the case control study was undertaken. Cases and controls did not differ significantly in terms of age or sex, and no significant association was found between case status and operating room, day of surgery, or time of surgery. However, the presence of one nurse, we'll call her healthcare worker number 1, in the operating room was significantly associated with case status. The nurse was present in 5 of 5 case surgeries and 6 of 20 control surgeries. Additional surgery observations focusing specifically on the statistically implicated healthcare worker were undertaken by Hospital A's infection control staff. Healthcare worker 1's surgical dress, scrub, and surgical techniques were observed and compared to those of other surgical personnel. No differences or deficiencies were noted. The identification of the sixth case in January of 2014 with a surgery date of April 2013 and the observation that healthcare worker 1 was present during that surgery led to the implementation of interim control measures. At the recommendation of the Department for Public Health, Hospital A excluded healthcare worker 1 from the operating room. The nurse was temporarily reassigned to other administrative duties. The following day, Department for Public Health investigators visited healthcare worker 1's home and collected samples from healthcare worker 1's person and from the environment in her home. Healthcare worker 1's hands, nares, ears, scalp, and hair samples were cultured for RGM. Environmental samples included water from the shower, washing machine, and an outdoor hot tub. Swab samples were collected from the shower head, washing machine, and the hot tub jets and filter membrane. While the healthcare worker 1 samples were being analyzed, the 7th and 8th cases, both goody eye cases, were identified in March of 2014 with surgery dates in October and November of 2013 respectively. Healthcare worker 1 was not documented to have been in the OR for the 7th case patient surgery, but was working in the surgical suite on a different case in a different OR at the time. Healthcare worker 1 was present in the OR during the 8th case patient's surgery. All samples collected from healthcare worker 1's person were negative for RGM. However, Mycobacterium walenskyii grew from the hot tub water sample, and Mycobacterium goodyeii grew from a swab sample from the hot tub filter membrane. M. walenskyii clinical isolates were found to be closely related to the walenskyii isolate from the hot tub by PFGE and by whole genome sequencing. M. goodyeii clinical isolates were found to be unrelated to the goodyeii isolate from the hot tub filter. After the identification of the 7th and 8th cases, additional joint replacement surgery observations were made by an external consultant, an infectious disease physician with experience investigating a previous RGM outbreak. The consultant compared surgical infection control practices at Hospital A with those at his own institution, which had a very low rate of joint replacement surgical site infections. The consultant observed important lapses in surgical infection control practices that had not been previously recognized. Surgical hoods and long-sleeve jackets were not consistently worn by non-scrubbed OR personnel, and consequently, excessive amounts of exposed skin were observed. He also observed that there was significant undocumented movement of surgical personnel between ORs during cases. Both of these observed practices were contrary to AORN guidelines. AORN is the Association of Operating Room Nurses. Based on the investigation findings, the Department for Public Health made the following final control measure recommendations. Hospital A should revise its policies to ensure that all AORN guidelines are followed, and specifically that during joint replacement surgeries, the skin of all surgical personnel is completely covered as can reasonably be achieved at all times, including the use of surgical hoods and, for non-scrub personnel, long-sleeve jackets snapped closed with cuffs down to the wrists. Policies should also be revised to ensure all AORN guidelines regarding traffic patterns in the surgical suite are followed, and specifically that traffic in and out of ORs during cases is minimized. Hospital infection control staff should continue to perform ongoing surveillance for additional cases. And the implicated healthcare worker should be encouraged to disinfect the hot tub or discontinue using it. Sorry about that. In summary, we investigated a nosocomial outbreak of RGM infections caused by M. Walenskyii and M. goodii among patients who underwent joint replacement surgery at a Kentucky hospital. We believe this to be, at the time, the largest reported outbreak of Walenskyii-goodii infections in the United States to date at the time. We found no evidence of environmental contamination with the outbreak organism in the hospital. The presence of a particular surgical healthcare worker in the OR was statistically associated with infection. This led to environmental sampling that identified an outdoor hot tub as the healthcare worker at the healthcare worker's home as the source of the M. Walenskyii, a result confirmed by PFGE and genome sequencing analyses comparing clinical and environmental mycobacterial isolates. We hypothesized that the healthcare worker's use of the hot tub, predominantly in the spring and fall months, led to transient skin colonization, explaining how the pathogens were introduced into the operating room. Identification of a reservoir and healthcare worker vector for this outbreak led to an external review of hospital surgical infection control practices, which identified critical lapses completing the chain of infection picture. Shed skin squames laden with mycobacteria contaminated the sterile field when the healthcare worker's bare skin was left exposed in the OR. In response to the findings of this investigation, hospital policies were revised to correct the infection control lapses which led to the infections. Implementation of these measures should help reduce the likelihood of surgical site infections not only from those microorganisms that caused the current outbreak, but from other microorganisms that might be present on any healthcare worker's skin. The source of the M. goodii infection is not clear, but correction of the identified deficiencies in basic infection control practices should mitigate that risk as well. And I would be remiss if I didn't point out that this was a team effort, not just with myself and my smaller team in Frankfurt with the Department for Public Health, but also reaching back to my CDC colleagues that did all the lab work and the infection control folks at the particular hospital and all the folks from the Northern Kentucky Independent District Health Department that were involved. So I always want to thank them, including Stacy, for their participation in the outbreak. And thank you guys. And okay, so I stayed on track pretty well. I think we've only burned up about half of the hour. So I have one. I just thought it would be fun. I don't know. But it was relevant to this. I had one additional little teaching point, and so since we're not real tight on time, I'll go ahead and hit that, and then we can just begin our discussion. So that's just an extra slide. But I just kind of glossed over something that you might have thought was strange or a little bit unsatisfying when I was talking about the odds ratio for that healthcare worker. So the odds ratio was actually reported, and I guess technically is undefined. And I just wonder, particularly from the students, because this is not necessarily as esoteric an issue as it might seem. It was very relevant to the investigation because an odds ratio is not just a tool that you use to identify a risk factor. Sometimes it's a tool that you have to use to communicate the risk to somebody else. In this case, we were trying to convince a hospital's chief medical officer why they ought to exclude a nurse from the operating room, which could have potentially very serious consequences to her career. And so it wasn't something that anybody was taking lightly at all. And so clear and effective communications were important. And especially when you're talking to somebody who, as a physician, probably has some knowledge of what an odds ratio is, but isn't necessarily going to be receptive to saying, well, in this case, the odds ratio is undefined. So it was relevant in those terms. But I just wonder from the students if you guys have a sense of what an undefined odds ratio means, yes.
Is it because you can't divide by 0?
It is exactly, in this case at least, it is exactly because you can't divide by 0, right? And as I pointed out there, that our statistically implicated healthcare worker was present for all of the case patients' surgeries.
Why don't you show the table again?
Let's see if we can.
Maybe go backwards.
Oop. Oop, there it is. Okay. Yeah. So you had all of the cases were exposed, which means none of the cases were not exposed, right? And so when we do our little AD over BC cross product guy here, that means you're going to get a 0 in the denominator. And, right, because other than 0, there is no number that you can multiply by 0 to get x. A number divided by 0 doesn't really make any sense, so it's considered undefined, right? So how would you communicate then what an undefined odds ratio means? Because especially to someone who says, I know that the higher an odds ratio is, the bigger sort of effect size that you're talking about, right? And so that leads me. We can go back to my little graph that I copied from Wikipedia, because I think this will sort of make the point. So if this is the function where y equals 1 over x, right? Or a number divided by some other number. Well, as x approaches 0, right? From the right, for example, you see that as x approaches 0, y is going to approach infinity, right? And the same thing as x approaches 0 from the left, y is going to approach negative infinity in this case. Now, in our practical case, right, you can't have negative cases, right? You can't have fewer than 0 cases in a cell. So we're really only talking about this quadrant of the graph, right? And so the best way to think about this is that an undefined odds ratio is really an infinite odds ratio, or an infinitely large odds ratio. Or it's suffice to say, it's really, really big. And the way that you can kind of think about this, and this will bring up the last kind of little point that I want to make about this, because there's probably a number of different ways that you can approach the math of having a 0 in your denominator for an odds ratio. Some of them are kind of complicated and sophisticated. Some of them aren't. One of them is called the Haldane correction, where you simply add 0.5 to all of the different cells, right? And then you can do the math, because your 0 goes away and all of the relative proportions should stay the same. And in some cases, other people have recommended just add 0.5 or a very, very small number to the 0. And then you can sort of do the math, and then you get an approximate odds ratio. But you can imagine, right? So if you were to do the Haldane correction, or let's say if you put 0.05 in place of the 0 in the denominator, right, you get a number. But then if you think to yourself, well, if I put 0.5 in there, why don't I get a little bit closer to the truth and put a smaller number that's closer to 0, right? Put 0.1 in there. And then if you recalculated it, your odds ratio would be what? It would be bigger, right? Because your denominator is smaller. And then you could say to yourself, well, why don't I get a little bit closer to the truth and put 0.01 in there? You can recalculate it and get a bigger. And you can see that you could do that ad infinitum, and off you go towards infinity. Yes.
Now, what I'm actually teaching the students is use the risk difference. And
Okay.
info gives you the risk difference. And the statisticians could probably explain why that's an imperfect approximation or something, but they're probably not here to say it. And
There's one.
And but what do you think of that? I mean, the epi-info gives it to you. It's the next best thing you can. You know, you're not writing for a medical journal. You're just trying to find out if it was the tuna sandwich or the bean dip
Right.
that caused the diarrhea, or what. You know, in this case, it was Nurse Smith or Nurse Jones. And then you pinpoint the right cause and get the job done.
Right. Yeah, absolutely. Okay. So that was just a little fun bit for the end there. So now I guess we can open it up to your questions. Yes.
How common is mycobacteria in hot tubs? Is there any data for that? There's tons and tons of hot tubs.
There are, and
So,
yeah.
issue of hot tubs.
So mycobacteria are actually pretty common in they're essentially ubiquitous in the environment, and they like to live in water, especially warm water. So, and as you saw, when we looked at the bulk water samples and we swabbed some wet areas in the PACU, we got back mycobacteria. It just didn't happen to be the particular mycobacteria that were causing this. So one of the takeaways from this, is not that is not so much that the hot tub is the problem, right? I mean, in this particular case, the hot tub was the reservoir for the particular organisms that caused these infections. But these kinds of environmental pathogens are sort of ubiquitous. And you can't go around, even though these kinds of things came up in discussions, you can't go around making policies about nurses not being able to use hot tubs or whatever, right? It's just not practical. And so, I mean, what the real answer is the appropriate infection control procedures. And that was, the labs. And it was, in this case, it was nice. And I don't think that we would have recognized, if we hadn't identified a particular reservoir and a particular healthcare worker vector, I don't know that we would have gotten the right person in to make the right kind of surgical observations to notice the infection control lapses that were going on. I'm not a clinician, so it wouldn't have done any good necessarily for me to go in and stand, in or outside the operating room and try and figure out what was going on. We relied on the hospital's infection control department, and they did the best job they could, but, even they didn't really recognize the problem with what was a common way of doing things at that hospital. And that was that even in joint surgeries, and apparently joint replacement surgeries, because they're easy for biofilms to get set up, they're particularly susceptible to these sorts of surgical site infections. It really took getting an outside investigator, Josh Pratish from the Mayo Clinic, and he fortunately had dealt with this in the past, and he went in and did these observations, and he said, this does not look like the way we do it at all. When we do joint replacement surgeries, everybody's got hoods on, and you shouldn't see any exposed skin anywhere. So that was the real thing, because it was kind of satisfying to complete that whole picture and to be able to say, we know that it was these mycobacteria, we know by PFGE and whole genome sequencing where these came from and how they got there and how they got into the operating room. But the real solution didn't go back to the hot tub. The real solution went, because even if our healthcare worker never set foot in our hot tub again, somebody else could. Somebody else could get colonized with something else from somewhere else, and so is the infection control piece that was most important. Yes?
So that seems like a great point, and that really is what makes it public health in a way, is that when you have to go to the chief medical officer at the hospital, you really in a way don't have to say it's nurse A who has to be individually targeted in
Right.
any way. It really is the public health issue of protective equipment in the surgical situation, right? So that
Yeah.
is that's what drives it from being an individual case to population health, and that seems like where the real kind of policy or guideline argument is.
Yeah.
It makes it a cool public health example.
Yeah, absolutely. Yeah, and so even though, and of course, and it was a very difficult thing to do, actually, to make that recommendation to exclude that particular nurse. I mean, by that point, we knew very clearly that this nurse was linked to these infections. And so we knew that it was the right thing to do to exclude her from the operating room, at least based on the information that we had right then, because we thought, at least at that point in the investigation, we thought that we hadn't, even though we'd done surgical observations, we hadn't found the key to it yet, that there were important lapses in infection control procedures that we hadn't yet recognized. And so, without that information, but knowing that this nurse still posed a risk, we had to exclude her. But it was important to eventually come back to that because, like you said, I mean, you can't tell people don't use a hot tub and stuff like that. Although, and a funny sort of epilogue to the story is that the hospital, although they took that point about the real solution being proper infection control procedures, did tell the nurse that they would buy her a completely new hot tub if she would just get rid of that old one, because we actually did some research about, is there a reliable way to disinfect a hot tub? And we couldn't find one. So the hospital said, you know what, this actually never made it into the media, which is probably a good thing, at least for the hospital. And I think they were really grateful to that, about that. And so they said, look, get rid of that hot tub and we'll replace it. And so she got a brand new, what was it, $10,000, $14,000 hot tub.
Just be recolonized?
Out of the deal. Yeah, potentially, right? I mean, but I guess there's that.
Did she have to take antibiotics? I think they did disinfect for him. They were like scrubs and.
Yeah, there was some information in the literature about decolonizing people with, I think, triclosan, but that's kind of toxic, and so we didn't encourage that. And she didn't have to take any antibiotics. So ultimately, the idea of decolonization didn't really, because she would just be recolonized, or it could potentially be recolonized from another source. Decolonization wasn't really a thing, and obviously this wasn't. It just didn't make her sick at all. It just got on her skin transiently, and you notice that we swabbed her, and so her colonization was obviously transient, right? Because while we could find evidence of these organisms in the reservoir, in the hot tub, we couldn't find them, or at least we didn't find them on her, which is a pretty good indication that it makes sense that this sort of colonization is pretty transient, right? She goes in the hot tub, she gets colonized, and maybe is colonized for a day or two or whatever, but after she's showered a couple times, there's probably no more Walensky-I on her. It's just those sort of transient, intermittent colonization events, and if they line up with her surgical schedule, then you have the risk for infection. Yes?
Have there been any cases since the preventive implementation?
No, there weren't. And I actually left and went back to NIOSH less than a year later. but I still know the folks there in Frankfurt, and I'm sure I would have heard if they had additional infections. That was the other thing about this, is that while surgical site infections aren't unfortunately necessarily all that uncommon, but surgical site infections, at least at the time, with these particular organisms are quite rare. And when we were looking into the literature to find out how we should go about investigating this case, there were actually relatively few outbreaks of M. Walensky-I or M. goodii. And in fact, the one that we really relied on was an example. We had to go to Israel. There was an example of a surgeon in Israel who was colonized, and he was actually colonized from his hot tub. We read about this in the literature. And so we always had that in the back of our mind when we were able to statistically implicate a particular healthcare worker. Our first question was, of course, does this person have a hot tub? And when the answer came back yes, we were like, oh my gosh, can it really be, this sort of neat and tied up in a bow? And we were, I guess in a sense, we were fortunate, that pointed us in the exact right direction. But this was a very sort of, not all investigations are like this, but this was a very sort of satisfying investigation in that sense, to be able to complete the whole picture and to be able to have the PFGE results that said, not only did we find Mycobacterium, this Walensky-I here in the hot tub, it is the same Walensky-I that was found in these patients' infected joints. The goodii, it didn't match up exactly with the clinical isolates, but, the presence of goodii, which is one of the rarer of these RGMs, means, there could be more than one colony. There could be, you can get drift, genetic drift in these populations, so they don't necessarily match up. I'm sorry, and you had a question?
I was just curious, because it seems like this would have been, besides the fact that the hospital initiated a more rigorous procedure and so forth, do they go on to use this as a mechanism to help educate the healthcare workers, including physicians, in terms of really driving home that importance of why these procedures are in place, and that they would revisit those procedures on every so often, in sort of a recertification of it? Is everyone really living up to what needs to be done? I was just wondering if they sort of took that as an opportunity to really drive that point home, as opposed to, here are some new procedures and this is what you have to do.
Yeah, unfortunately, I suspect that it was closer to the latter than the former. I think that the hospital had potentially a lot to lose riding on this, and I think that at the Department for Public Health, obviously we had a role where we needed to protect the public's health. In this case, the public that we were dealing with was limited to the patients here, and we felt like the control measures that we took, and we took the control measures that we did just for that reason. We didn't feel like we ever had to sort of make a general announcement to the media or to the public, saying avoid hospital A and stuff like that.
I'm not suggesting.
No, right. Yeah. But I'm just saying that had this information, and it wasn't, at least in this set of circumstances, it wasn't going to come from us in that way. But had this information gotten out, and had each of the case patients known about the other case patients, and had this been recognized as an outbreak, there could have been a good deal of liability that the hospital, and so I think the hospital was really nervous about that. I mean, on the one hand, certainly the infection control department and everybody, they cooperated with us, and they did the right thing. But I think you could sort of sense that the hospital wanted this to be done and over with, and you sort of see that in their, what you'd have to describe as their emotional reaction to replacing the hot tub, you know. They wanted this to be done and over with and behind them, and I think they were certainly rigorous in implementing the procedures or the new guidelines, but I don't think they had any interest in sort of revisiting the fact of an outbreak. Now, I don't know, you know, when they had their infection control committee meetings and stuff like that, I wasn't present for that. I mean, I'm sure that certainly within the infection control group, this was known about and discussed and stuff like that. But I just get the sense from my involvement that that it hit maybe a little too close to home or a little too close to the bottom line for them to have that attitude of, you know, this is a great opportunity to use this as a teaching tool and stuff like that. So,
So I'm a layperson, I have epi, but this makes me never want to get into a hot tub again. But
Never go to the doctor.
but why is it that other infections, like STDs, for instance, are not colonized? I mean, it seems like this would be just proliferating in hot tubs all over the world. Like, if you can't affect it,
You're a little ray of sunshine.
So I think that the thing to keep in mind there is the difference between colonization and infection. So the healthcare worker, when she got into her hot tub, she didn't get infected with Mycobacterium lewinskyii. She just got colonized with it, meaning it was present on her skin. And Mycobacterium lewinskyii, Mycobacterium goodii is not something that is likely to make anybody sick unless it just happens to be lucky enough to have the opportunity to get deep inside their body and beyond their initial sort of immune defenses. And so you're going to be able to, you're exposed, and you know, obviously there may be something to say here for environmentalists about proper chlorination levels and everything like that. But you know, you can't really avoid yourself getting contaminated with environmental bacteria. That really wasn't the thing. This was just sort of highlighting our ability to specifically pinpoint where in the environment these particular microorganisms came from that caused these surgical site infections. So yeah, I wouldn't worry about getting in the hot tub. As long as it's properly operated, go ahead and get in the hot tub. Just take a shower afterwards.
My takeaway,
Uh-huh.
I would suggest to all students and learners that this really demonstrates how epidemiology can be successful even at the margins of undefined statistical precision. We can actually get a right answer even when you get a association that's just got a confidence interval that goes to infinity.
Right. Yeah. Right. Yeah. Yeah. No. Yeah. That's a good point because Yeah. All we needed was that sort of big flashing sign to point us in the right direction. And
second comment. Reservoir, hot tub. The link between the two words that you're thinking that's going to be like a big hot tub.
Yeah, I don't know. It was like a 4-person hot tub. Yes.
I have 2 questions. Before you were able to identify the healthcare worker as the source from the hot tub, did you look at the devices, the implants, that the devices didn't come from the same company? And the second question is, at the initial part of the investigation, were you concerned about the power because of the cases? There were obviously not many cases. Were you kind of concerned about the power?
Yeah. So we did look at the devices. I don't remember specifically what the manufacturers were. I think that the devices, there wasn't really any devices there wasn't really any difference in the devices, and we didn't calculate an odds ratio for this, but I think that because we were talking about a single orthopedic practice, and they got all their devices from the same manufacturer, and so we knew, and this was the only, I don't know, obviously this took place in northern Kentucky, but this was not only the only orthopedic practice that operated this hospital, essentially it was the only orthopedic practice that operated in northern Kentucky. So we didn't include that in the case control study just because because essentially it wasn't a variable, it was sort of a constant, the manufacturer for the devices, although that certainly did come up. And yeah, we were concerned about power because it was a very small study. And this kind of gets to what Dr. Baumgartner was saying. You know, there's not much you can do to adjust the power of your study other than sort of get a bigger sample size, and that's obviously not acceptable here. What we had to do was hope that we had a large enough effect size that we would be able to recognize it in the case control study, and in this case we did. But yeah, and I mean, so the only consideration that we made, I mean, the only consideration that made a difference in what we did in terms of power was just to use the sort of rule of thumb is that in a case control study, you want to get to sort of maximize your power, you want to get 4 controls per case. Beyond that, you're probably not increasing the statistical power very much. So we did know that having just a handful of cases that we wanted to get at least 4 controls per case, which wasn't entirely irrelevant because it actually took quite a bit of work on the part of the infection control staff to sort of select and then abstract data for these cases. And so it's not something that we did just sort of reflexively. When we went to the hospital and said, we need you to abstract this data from these medical records, we need to do it for all the cases, and we need to do it for this many controls, you know, when we did that, we wanted to go to them with the least amount of work that we had to require of them, but we knew that because our sample size was so small, we had to get at least 4 cases per study. But I mean, for power, I mean, you can either increase your sample size or you can sort of look for a larger difference. But other than that, I don't really know any way to increase your power.
The key thing beyond the statistical limitations is that to some extent you knew what you were looking for. The experience, logic, and those were the more important things that you were operating off of. The environment, the context, the situation.
Yeah.
And, you know, if you were able to do some sort of continuity correction or something on that odds ratio, it's still huge.
Yeah, right.
You know, and,
How many
it's
factors?
like the 3 blind men who went target shooting. The 3 blind statisticians who went target shooting. One missed the target 12 feet to the left, the other 12 feet to the right, and the third said, I guess we hit it.
Right.
How many factors, like how many different 2x2 tables did you end up creating for the case control study? How many different risk factors did you look at?
Well, we had a lot of 2x2 tables, and Stacy did this because I mean, we looked at, and it was on here. There wasn't a ton in terms of. Let's see if I can go back. Oops. Yeah. So we had 2x2 tables for sex, for the operating room, day of surgery, time of surgery. So that wasn't such a big deal. But this is the thing. And Stacy actually had to do all these tables. And so we had like for each person present in the operating room, I mean, we had like 40 different healthcare workers or something that we had to look at. So there was,
That's what I was wondering.
yeah. So there was a bunch of those mainly for that reason because we calculated a separate odds ratio for each person present in the operating room. So that, yeah. So
She was the only one with like a 5 and a 0.
yeah.
Okay.
Yeah, everything else, and as you know, you might think that with so many that just sort of randomly, right, that you might have some statistically significant people pop out, especially with all these repeated measures, but because of the small sample size, in order to stand out of that many, I mean, it had to be a really big effect. In order to achieve statistical significance. And none of the other ones achieved statistical significance at all, except hers, because you practically, with such a small sample size, you'd almost have to have an effect size that big in order to get statistical significance.
Any other questions?
This isn't a question, but please don't forget to sign the sign-in sheet. And could you please fill out the evaluation form in front of you? Thank you.
And thank you guys. I enjoyed this. It's fun.